not a computational scientist, so I will give a clinical talk in the continuity of Dimitri's talk, and I will try to draw a picture of the current status of artificial intelligence at the service of nuclear medicine techniques in the field of oncology with a clinical focus. So, first question, very simple question, basic question, is this cancer? So when you look at these images, you've got two patients with a hot lung lesion and several lymph nodes. Cannot tell really the difference between this infectious disease, this cancer, adenocarcinoma. So when you are speaking of artificial intelligence, whether it's simple machine learning or deep learning, essentially you've got to put forward a problem, a question. So the problem here to solve is this cancer or is this something else? First study that was published here recently, 85 solitary pulmonary nodules, a large prevalence of cancer. 65 of these 85 lesions were cancer lesions. They performed dual time point FDG PET. Dual time point is a bit odd because it's an old concept, but still I like it because the authors, as Dimitris mentioned, try to get into the temporal dimension of PET. So, and dual time point is one way to do it, but we know that with the new digital PETs, it's much easier to do dynamic acquisition, so I think it's interesting. That was performed in one center with one PET device, and the machine learning algorithm is a simple machine learning algorithm that's a support vector machine. This is very boring, but it's important because the methodology is important when we read the papers, because we need to try at least understanding what is it that the authors, the researchers did when they used machine learning. In this case, they tried to combine all those features using this algorithm to answer that question, is this cancer or is it not cancer? And the way to report it is the area under the curve. The higher up, the best it is. You can see here, this curve, it's the retention index. That's the evaluation of the uptake over time. It doesn't work very well. That's the physician score. It's not too bad, but the best one is over there. It's either the delayed PET machine learning model or the early AND combined with delayed PET. If we look at these images, at these figures, the area under the curve, or the models, finally, the best one is that one with an area under the curve of 0.90, which is very good. And if we look at the sensitivity specificity, again, the best one are those one, of course, with accuracies of 0.86. So that's very well. That's very efficient for a machine learning algorithm that is without intervention of the human. How the physicians is doing to answer that question, is this cancer? Well, not too bad. When you look at the accuracy, it's very similar. But if you look at the sensitivity and specificity, you can see that in this case, the physician's interpretation tends to promote sensitivity. So another lesson, if we read the literature, even though the area under the curve is the primary metrics that is used to evaluate the performances of various diagnostic methods or machine learning algorithms, it's also important to look what's behind the area under the curve and look at the sensitivity and specificity, because of course, depending on the clinical situation, we may want to promote either sensitivity or specificity. Second question, I know it's cancer, or there's a very high likelihood that the lesion is cancerous. What type of cancer is this? In this example, those two nodules, very hot nodules, in one case it's a small cell lung cancer, this one is a squamous cell carcinoma. So very similar radiologically and metabolically. So the problems are multiple. You will ask the machine learning algorithm to solve the problem, is it a primary cancer or is it a metastasis? Is it a non-small cell or is it a small cell? And so on and so forth. And here the group in Milan performed a series of very, very nice experiments. In this case, they studied over 500 patients. that had either adenocarcinoma, squamous cell carcinoma, other primaries, or metastases. They extracted 43 features, just as Dimitris explained to you a few minutes earlier. Data were acquired using 2 different scanners, and the machine learning algorithm that they used was that one, LDA, linear discriminant analysis. So to answer the question, is this lesion a primary tumor or a metastasis? Well, the algorithm got the answer with an area under the curve of over 90, which again is very, very nice with a very tight confidence interval. If the question is it adenocarcinoma or squamous cell carcinoma or other, a little less. Further less if the question is the other way around. Is it squamous cell carcinoma or adenocarcinoma and others? 0.61. And so on and so forth. But overall, again, very encouraging, because all you have to do is to point the lesion and then manage these radiomic features using this automated algorithm, and you got an answer with a reasonably high accuracy. Next question. I know what type of cancer is it. Can I go further into the characterization of that lesion? For instance, genetic characterization. This is an example of rectal cancer, and we've been looking at various metabolic, for instance, activity or heterogeneity features to try to characterize those rectal cancer regarding KRAS, NRAS mutation. And we and others, we failed to identify any reproducible radiomic parameter feature to predict the RAS mutational status, or we could observe that those mutated tumors tended to be hotter with a higher SUV max than the others, but that's it. And these researchers compared the SUV max that did not perform too well with an area under the curve of 0.58, but they looked at the CT texture features. So they extracted some information from the CT data, and with that, they were able to predict the mutational status, or KRAS mutational status, with an area under the curve of 0.82, which is quite nice. So this is very encouraging. This is something, well, encouraging for the radiologist, if I may say, but this is something that we have to keep in mind. It's that this is a trend. We are lagging a little bit behind in nuclear medicine. Artificial intelligence is further advanced in the field of radiology, and we may be very surprised by all the information that could be extracted from CT studies. Now, as always, you have to look at everything, and in this case, even though the paper is very well done, very interesting, but in this case, the CT features were extracted from the tumor, of course, but the tumor was manually delineated by the radiologist. And, you know, the combination of manual definition of the target, the lesion, plus artificial intelligence, machine learning, is not the best one. So be careful and look beyond just the AUC. Next question, how advanced is the disease? For instance, regarding lung cancer, with PET, we cannot tell what's the T stage. We cannot measure precisely the local invasion of the tumor or the precise size of the tumor. So the problem here is it early T stage or advanced T stage in non-small cell lung cancer? And again, the group in Milan used data from PET, low-dose PET-CT, again, close to 500 patients, non-small cell lung cancer, a majority of early-stage patients, and in this case, they used deep learning, a convoluted neural network, and interestingly, they combined the low-dose CT data with the PET data, because you can say, okay, this is not only PET data, but of course, we are doing PET and CT, so we've got to use everything that is at our disposal and try to extract as much information as we can. And in this case, the algorithm was able to predict the T stage with an accuracy of 69%, a recall rate, that's a measure of the sensitivity of 70%. And it's not that high, you may say, okay, it's not very good, but it's not that bad considering that we come from zero practically, and the gold standard was very, very strict, as the T stage that was considered as the gold standard was obtained at surgery in 80% of the cases. So again, very encouraging. If we move on to what's more familiar to us when it comes to staging lung cancer, that's the nodal staging. Here, 168 patients, they analyzed almost 1,400 lymph nodes. About 10% were malignant. And here is the report of various machine learning algorithms. This is random forest, this is support vector machine, this is deep learning, and so on and so forth. And you can see that all perform in the similar range with an accuracy ranging from 80 to 85%, and the sensitivities and the specificities are also within the same range for defining whether the patient is N0 or N+. How does it compare to the nuclear medicine physician? Well, the accuracy is also in the same range, but again, there is a difference. Here, the sensitivity of the physician is consistently lower, whereas the specificity is higher. In this case, considering the clinical situation, you may want to promote sensitivity rather than specificity. So look beyond the AUC. Other question, what are the limits? What are the exact boundaries of the lesion? I know it's a tumor, it's a target lesion. What are the exact boundaries? It may be difficult. Here, this is an infiltrating cervical cancer next to the bladder. This is a PSMA scan with a recurrent, or again, next to the bladder. Or here, this is a locally advanced head and neck tumor with very complex lesions. So what are the exact, precise delimitation of the tumors? In this case, it's interesting because it's a combination of deep learning, that's the most advanced form of machine learning, plus what they called anatomical priors. So basically, you ask the algorithm to identify and draw the limits of, in this case, a cervical cancer. That is something that is grossly round, spherical, and usually behind another hotspot. So that's the process the machine learning is trained. And these are various segmentation algorithm. This is the deep learning algorithm. The red line is the truth as defined by the physician. You can see that in all cases there are mistakes performed by these algorithms, but in the deep learning algorithm, there is a very good congruence between the red and the green lines. That means that this algorithm is capable of recognizing the tumor compared to the bladder that is next to him and define the limits of the tumor next to the other hotspot. Why would we do that? Well, there are many applications, of course. If we remove the human hand, of course, we increase the reproducibility. We decrease the inter-observer variability. That could be very helpful for defining the tumor volume to be irradiated for the treatment planning in radiation oncology. Here we have 3 examples of 3 very different tumor cancer lesions with, depending on the solid, subsolid, or ground glass aspect on the CT. Another potential, very potential application, but one of the interest of artificial intelligence is that it may bring to the field indications that were never considered reasonable for nuclear medicine. For instance, screening. Screening, we don't use nuclear medicine for screening because for once you need to be sufficiently accurate, but also the radiation dose is very important for screening. And here you have 3 images. That's one patient. That's here the image of a lung cancer with the total of the dose, 186 megabecquerels. The effective dose is 3.7 millisievert. If you keep 10% of the counts, you decrease the activity injected to 18 and the effective dose to 0.37. 1/3, only a few megabecquerels, and the effective dose 0.1 millisievert. So that becomes very, very low. Of course, in this case, you've got very, very noisy images. If you look at the images, you cannot use the images. But could an artificial intelligence algorithm make some sense out of these very noisy images? Well, in this case, it's not bad. These are the three curves. This one is the deep learning algorithm performing for recognizing that lesions with all the counts in the images with a very, very high AUC, of course, and an accuracy also very high, 97%. But the red curve, which is not far away from the other one, with an AUC of 0.97 and an accuracy of 93%, which is quite good, with only 3% of the counts, so less than 1 millisievert exposure for the patient. So, proof of concept, but that's quite interesting. Next question, can I predict, with the help of AI, what will happen to my patient once I've started treating him or her? So there are many questions, many problems to solve within that questions. Short-term questions, is it response, non-response, progression, pseudo-progression, and eventually what will happen to my patients? Will there be recurrence? Will there be death from cancer? It may be difficult. Here, especially with these new treatment regimens, here we have metastatic melanoma treated by immunotherapy. You can see here a complete response, so very good response. That's interesting. So we want the AI algorithm to recognize the response, but also you can see here increased uptake in the lungs. That may be a complication of the treatment. So ideally, we would like the AI algorithm to also recognize that. So that's another problem to be solved. In this case, lung cancer, again, immunotherapy. This is not progression. This is a very good response with treatment-induced sarcoidosis. So complex question, can AI help us? How can we use this metabolic information? We've been trying for years, for decades. We know that there is information in the metabolic image. We know that hot is not good. Here it's early stage non-small cell lung cancer, and we can see that the prognosis of the lesions with a higher SUV is worse than those with a lower SUV. So we know that big is not good. Within the same stage, we know that the high metabolic tumor volume is associated with a worse prognosis compared to those with a lower MTV. We already know that also that several radiomix parameters taken separately can also predict, so as a measure of heterogeneity, the outcome. Here, this is in rectal cancer. You can see that those patients with a higher coarseness have a shorter disease-free survival than those with a low coarseness. So we know that. It's been proven time and again, and yet our oncologists, our surgeons, they don't take that into account. The treatment is not modified depending on the SUV max of the squamous cell carcinoma or the adenocarcinoma. It's modified depending on the stage, on the mutational status, EGFR, so on and so forth, but not based upon our parameters. So could, as Dimitris alluded to earlier, could we combine intelligently all those parameters, possibly with others, and together could we improve the prediction of the response to treatment? In this case, this patient with non-small cell lung carcinoma, you can find that, okay, contrast, again, another single parameter that shows nice separated Kaplan-Meier curves, so that's good. But when you use a machine learning algorithm, you can see that you can reach a fairly high accuracy with an AUC of 0.95 and a 90% accuracy. So that's very good. What you also see is that you have to try several machine learning algorithms. They are not all equivalent. you see this support vector machine that was very useful earlier in other indications. Well, in this case, it's not very good. It's not good at all, actually. So one is not equal to the other. The short-term response. If we look at these parameters in patients with osteosarcoma, can we predict the pathological response after chemotherapy? On baseline, we cannot. So none of these parameters are effective. We could, if we repeat the study just after the chemotherapy, before the surgery. In this case, we got a nice prediction, but we've done 2 studies, and we look at the evolution of the uptake over time. So that's good. With machine learning, we may be able to extract the same quality of information, the same level of information on the baseline study. That's what these authors did on the baseline study with this machine learning algorithm with an AUC of 0.82. Again, quite encouraging. So this is all nice and well. Good results, interesting results. How does it work in the real world? This is something that we've done in Liège. It's not been published yet. It will be presented at the IEEE meeting in 2 weeks, I believe. We looked at about 150 locally advanced cervical cancers coming from 4 different centers with different machines, different acquisition protocols. Could we, as Dimitri said, could we harmonize the data, pre-process the data so that, or post-process in this case the data, so that we could build a model that is valid everywhere? So I won't go through all the process, but we did everything we could to optimize all these parameters that were described in the chain by Dimitris in order to eventually, we tested several machine learning algorithms. We ended up with this one, SVM. The feature selection method was that one. The discretization of the image, the optimal was this one. The best features were that ones, and so on and so forth. And we ended up with an AUC of 0.77. And we were very, very happy with that, because if we look at that, we stop there, we have found a model that could be applied basically, possibly, almost everywhere. 0.77, it's not perfect, but it's quite nice. Yes, and indeed, you have very nice separation in terms of survival probability depending on the results of this model. So that's very good, nice. The problem is that if we go back to the feature selections, we have several methods to select the features that will be analyzed by the model, okay? And if we look at the various centers, and these are the various methods for extracting the features, we want a dark blue line horizontal. We want a method that is efficient in all centers. We don't have that. We have some sort of patchwork. It means that what works for the whole population doesn't work necessarily for the Barcelona patient, the breast patient, the McGill patient, and so on and so forth. That means that even though overall we were able to end up with a model that was predictive, statistically predictive, when you analyze deeply the data, where there are indications that actually our feature selection is unstable and there is a large contribution of randomness in the results. So basically, as a conclusion, I think I've shown that there is a very high impact potentially in all aspects of nuclear oncology, aspects that we know and possibly others. The current results are very, very encouraging in my opinion, but they are not really compelling at this time. We are facing, as Dimitri said, a long and complex validation process. We need big data, we need large amount of data, but we also need high quality data. We need to be very, very focused on the methodology. We have to make sure that the end result is fully validated. And we have to understand what we are doing, which means that the physicians need to be fully involved in the process of testing and validating those algorithms, not only with regard to the diagnostic accuracy, because if it works, if it can be applied in the routine clinical practice, right away, there will be some very important ethical and training issues. Thank you very much for your attention.